We behave as if the one thing that matters is staying alive, rather than the quality of the life that you're having. I was saying to myself, David, what do you think you're doing? You're a country GP. What on earth are you doing here? And the other bit of my head was saying, yeah, what an opportunity. Just go for it. Tell them what you think. When faced with opportunities, apply that test, what I call my deathbed test. Would you regret not giving this a shot? If so, go for it and have an amazing life.
Welcome to the MedConception podcast, a podcast about leading a healthy and more mindful life. Today, we have with us Sir David Haslam. How are you doing, sir?
I'm doing really good. Thanks, Andres.
It's amazing to have you on the podcast, and it's an honor. As I say always, I'm going to say a few words about you, and then we can proceed. So, Sir David Haslam is a British medical doctor, writer, and administrator. He is a professor of general practice with 36 years of practicing experience. He has been president of the Royal College of GPs and the British Medical Association, and a past chair of NICE. Sir David is currently chair of the Trustee Board of the cancer charity Young Lives versus Cancer. Over the last few decades, he has published over 2,000 articles, as well as 14 books in both lay and medical press. For over 10 years, the Health Service Journal described him as one of the most influential people in the NHS, and his latest book, Side Effects: How Our Healthcare Lost Its Way and How to Fix It, has just been published. From the few stuff I just read, you can understand that if you read deep into Sir David's biography, it's amazing. It's amazing what you've achieved.
Listening to a list like that, it feels like my obituary is being printed. But it's the way I never planned a career like this. My ambition was to be a family doctor, a general practitioner, but it's been a real honor to have some of these roles and have the opportunity to work with all sorts of interesting people.
How comes you went into general practice?
Probably a couple of reasons. The simplest one is my father was a general practitioner. He died when I was quite young. I was still only about 14 years old. And so he was a bit of a hero to me. But I remember going to his funeral and seeing the church packed with patients who were so grateful for the impact he'd had on their lives, the real importance of him to them as a family doctor. And then when I was a medical student, I was interested in pretty well everything that I studied. And so the logical thing was to be a generalist. The one thing I couldn't be was a surgeon. I'm so useless with my hands that going into any of the surgical specialties would have been quite dangerous. But it was wanting a bit of everything.
This is it's a decision that we all called when we're medical students to choose between generalism and specialism. I think we could address this. What do you think? Why do you think journalism is looked down upon? I think
it's a question that the more I think about it, the more extraordinary it is. We have this bizarre thing in many Western cultures that says the smaller your area of expertise, the higher your prestige. So if you're expert in, the left lobe of the liver, that's seen as really, wow, that's something to be impressed about. If you're the sort of doctor who deals with most of the problems of most of the population most of the time, that's seen as somehow a lower order skill, but it isn't. It's an incredibly high skill. I believe to be a good generalist, a good general practitioner or general physician is probably the hardest job in medicine. But we have this bizarre different view of it. And as I say, the more you think about it, the crazier it is. And I think it applies to other professions as well. But for reasons that maybe we can talk about, I think generalism is the future rather than the past.
Why do you think that?
Mainly because we all hear about the aging population in all our countries, the number of people who are surviving and living with multiple conditions. and that is becoming the norm. In the United Kingdom, for instance, there are more people with two or more long-term health conditions than there are with one long-term condition. I had a patient I remember very well who had, let's see if I can remember, he had coronary heart disease, hypertension, hyperlipidemia, diabetes, osteoarthritis of the hip, macular degeneration, depression. I've forgotten one, but there were around about 8 conditions. Now, if you have to go to a different doctor for each of those conditions, that's your life. I mean, that you would do nothing other than have hospital appointments. And the real need and the real skill to have people who can care for the whole person rather than just bits of them, I think has never been more important. Yes, of course, we need the expertise of the specialists, but to take a holistic view of any of our lives, I think requires a trusted generalist.
I think this is a good segue into what a general practitioner does. This holistic view of a patient and this taking every step of the journey, being with them. Could you talk about a bit about this, how a general practitioner works with a patient and what is its relationship? Well,
there's a number of ways you can look at the GP's relationship with a patient. I mean, in an ideal world, you have a doctor that knows you and you know the doctor. There's a lot of evidence and increasing evidence that continuity of care, of a relationship that's ongoing between doctor and patient, is good for health. It reduces the need for medication and treatment, much of which is often unnecessary. It reduces the number of hospital admissions, reduces the cost of healthcare, and improves outcomes. The critical thing is that it improves outcomes. I've said many times, that if continuity of care was a drug, we would all demand it. We would all insist, because of the value of that. But the key role of a good generalist is to look at their patient in a multiplicity of ways, in physical, psychological, and social terms, to understand what matters to the person you're caring for, as well as what's the matter with them. The danger of a too focused, approach is that it ignores all the rest of that and doesn't take into account patient preferences and what they, what really matters to them.
So what I get from this is that every patient needs a GP, and this kind of debunks this idea that that we see that a lot of people are like, well, maybe I don't need a GP. I can directly go to a specialist. And also, could you talk? Yeah.
You're absolutely right that people feel, this is crazy. Why do I have to go through a middle step before seeing a specialist? And of course, sometimes it's perfectly obvious what you need, what care you need, what sort of specialty. But if you've got abdominal pain, who do you consult? Do you see a surgeon? If you're a woman, do you see a gynecologist? If you've got back pain, back pain is the most classic example. Do you see a physiotherapist? Do you see an orthopedic surgeon? Do you see a kidney specialist? Do you see a rheumatologist? And what we do know is that there's a wonderful saying that to a man with a hammer, everything looks like a nail. In other words, people tend to behave in a way that fits their profession. So the chances are, if you see an orthopedic surgeon, you'll end up with orthopedic things being done, and that may not be appropriate. That's why sometimes it's really helpful to have a skilled person on your side who's helping you know if you need specialist care, where the best way to go for it is. I said back pain there, I said abdominal pain. Headaches, of course, are even more the case. Who would you see about a headache? Would you see an osteopath, a chiropractor? Would you see a neurologist? Would you see a general physician? It may be none of those, so trying to unpick this is really difficult and made even more difficult by the use of Dr. Google. So many patients now will type their symptoms into Google, and it pretty well guarantee it'll say you've got cancer and need seeing urgently. whereas a skilled physician can really help so much better.
I totally agree. And I think this is something that we should highlight, is that not any specialty doctor can act as a general practitioner, because as you said, any doctor with a HAMU, or if you go to an orthopedic surgeon, the problem would be orthopedic related. And following upon that, what about patients have this idea that we come to doctor when we're sick? And I think there's another key area that general practice plays here, is that general practice sees patients when they're doing okay. Could we talk a bit about that, and how does that work? And in a more practical way, how long further apart should patients see their GPs?
I mean, it varies hugely, and I think in the real world, we've got to face up to the fact that in most countries there aren't enough GPs at the moment. There's difficulties sometimes accessing GPs. So the way that they're used is going to depend very much on what the facilities you might have in a general practice locally are. I mean, I believe that ultimately in the future we're going to need significant teams based in and around health and social care that can be there as a general support to people, helping with issues like prevention, like ensuring, things like blood pressure are checked on a regular basis. This doesn't always need the GP to do it, of course. There's other members of, you can have nurses, you can have pharmacists, others who are involved in this. But prevention can pay so many dividends, but it's something that most people, and particularly most politicians, tend to ignore.
What about some practical things that patients can do for prevention? The critical thing, I think, from a prevention perspective, the most important ones are weight, smoking, alcohol intake, and blood pressure. I think if people keep an eye on those, if they get most people can do this themselves, indeed. I mean, things like blood pressure machines are now very, very cheap, as long as you get one that's certified as being competent. You can keep an eye on your blood pressure. Obviously, we can all keep an eye on our weight. Please, 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 nobody smoke. There is no such thing as good, safe smoking. And alcohol intake, different countries, different guidelines, but again, keeping an eye on these. These are the really, really important ones. There's hundreds of other possible tests that people can have. Many of them are much less valuable than those. Do those 4 and keep exercising, and I think you're in for nobody can guarantee anything from a health perspective, but it'll give you a better chance. I think that most people do know these. They're at the back of their minds. Why do you think people, although they tend to know them and they tend to know the negative consequences of them, why do you think people continue doing them? Why do you think people continue smoking?
I think there's addiction comes into it. I mean, obviously with smoking particularly, it is a highly addictive drug. So there's a real addiction linked challenge to stopping. But I think there's also, people misunderstand some of the statistics. I remember so often patients saying to me that, I had an uncle, they would say, that lived to the age of 90 and he smoked 50 cigarettes a day. So that proves that you doctors are wrong. No, it doesn't prove anything at all. It proves that he survived the risk. You can drive down a very busy road with a blindfold on. That doesn't prove that it's safe. The fact that you get to the end of the road alive doesn't prove it was a safe thing to do. So I think folks just take a far too black and white. If I know somebody who smokes and they're still alive at an old age, it must be safe. No, that is not true.
I think this highlights basically prevention. Do you think that, how would you go about educating young people on prevention?
Well, educating on young people on prevention is incredibly difficult because, as we all know, people as old as me can remember, when you're young, you feel that you're immortal. The thought of sort of long-term illness doesn't cross your mind, and thank heavens for that. But I think schools have a part to play, and I think, interestingly, schools have a major part to play in helping the parents, because if you educate, I've seen it with my own kids when they were young, and my grandchildren now, if they're educated at school, they go home and nag the parents, Dad, you shouldn't be doing this or whatever. So I think it can have a profound effect across society if you get talk about preventive issues into schools.
I've also seen that a lot of the times we focus on the long-term effects of bad practices, such as obesity, such as smoking, what we just mentioned. But I really do feel when young people are our age hear about problems that would come up in 30 years, as you said, they feel that's too far away. I can stop it in a year or two, or I can change who I am later on. What about focusing on the short-term effects of these bad habits?
Yeah. No, I think you're absolutely right. I mean, it's talking to a 16-year-old about if you look after yourself, then you'll be healthier at 50. That's just crazy. I mean, why are they going to be interested? It's something that is completely, for most people, it's something that's completely of no interest at all. Which is why, certainly in the UK, there've been effective campaigns on smoking aimed at young people that are focused on things like your breath smells or, impacts like that, or other people's approval or disapproval. And that, of course, is completely different to the long-term health benefits. But there's no point in focusing on those if they're not going to get traction with the audience you're talking to. You need to find, and the last person in the world to talk about what young people need to hear is someone like me. This is health education campaigns for an age group like that need to be developed with that age group.
Mm-hmm. What about, I'm going to go back to being a GP. What is it like on an everyday basis?
The thing that I loved about being a GP is that you have absolutely no idea what's coming next. It could be, I remember in a single day seeing, I think the youngest patient I saw on this particular day was about 18 hours old. So, a baby who'd just been born. And the oldest person on this particular day was 97. And so you've got that extraordinary spread of age. The fact that you have no idea if the next person coming in has back pain or the first symptoms of a really serious disease, or they're pregnant, or they want advice about something, or they're seriously depressed, or they have the early symptoms of schizophrenia. It could be absolutely anything. And so you have to have your antennae up all the time to be aware. And of course, most people present most of the time with relatively harmless things, but there's no excuse. Well, it's really important that you develop techniques as a GP to spot when this symptom is a bit more serious, and be aware of that. So you've really got to be on your alert the whole time, which makes it hard work. And as I've said, really skillful work to do well. I said earlier, I think it's the hardest job in medicine to do well. It's also probably the easiest to do badly. And this is why focusing on the quality of GPs and the education of people who are going to work in general practice is so incredibly important.
I can see this in practice as well. I wanted to, as you described, you have to be on your toes constantly. And I think this is something that is mentally demanding and psychologically demanding from GPs. I was reading the study from the American Medical Association that said that, this was in 2020, 46% of family medicine practitioners reported symptoms of burnout. And if we compare that to other professions, they had, for example, ophthalmology, which is 30%, orthopedics, 34%, general surgery, 35%. We're talking about 10% more burnout in general practitioners. Why do you think that's? I think you answered why that is the case pretty clearly. What can we do about this?
Ultimately, it requires time. So you need time in your working day, or certainly in your working week, to be able to stop, to reflect, to be able to share the challenges that you've got with other colleagues. If all you do is see patient after patient after patient after patient, you will burn out. It's so demanding and so anxiety provoking. You know, the awareness that the patient who came in with a headache, it may be because they're unhappy because, you know, there's problems in their family, or it may be the first symptoms of a brain tumor. And knowing that it could be either of those is very potentially anxiety provoking. So we need a large enough and skillful enough workforce in primary care for people to also have time in their lives. And again, I'm absolutely committed to the importance of expanding the GP workforce so that people are able to focus on quality and to deliver things like continuity that I've talked about earlier that are so important to our patients.
Do you think the NHS is giving the deserved attention to what you just mentioned, or the funding?
Absolutely not. No, absolutely not. We've seen over the last 10 years or so the number of hospital consultants go up by, I think the figure in the last 10 years is something like 80%. I can't remember the exact figure. The number of GPs has gone down very significantly. And yet this is with the government that promised to expand general practice numbers. And again, I think the focus is always on the perceived two things. What the perceived glamour of hospital medicine. It looks much, much more exciting to politicians. They can understand the drama much more. For the reasons we talked about right at the beginning of this discussion, Andreas, people undervalue the role of generalists. They think it's less important, and actually, it's the keystone to the whole functioning of the health service. I remember talking to when Tony Blair was British Prime Minister. I remember describing general practice to him as what I called the risk sink of the health service. In computers, you have this thing called a heat sink, which sort of absorbs heat and out of the system. And if it wasn't there, the system would crash. Well, I think general practice does that with the health service. If every single patient that presented to the NHS today with a headache was treated like they would in a hospital, in other words, they all had scans and they all had further investigations, the system would be crashed by tomorrow. You need someone really skillful to know when these sort of tests are necessary and valuable and when they're not necessary and valuable.
I think this is another point that it's a good point to bring up your book now, because this is something that you argue in the book as well. I've gone through quite a bit of it, and I have to say that firstly, I love the way that you write. Your writing style, it's very easy to go through, very relatable. And the stuff you say, I think it's stuff that has to be addressed. Yeah,
no, that's very, very kind of you to say. I mean, the chief thing I was trying to say was I think there is a complete lack of clarity about what we're trying to achieve in healthcare. And the thoughts really came to me when I read a while ago the biography of a general practitioner in the UK who was practicing in the 1860s, so a very long time ago. And looking at his typical morning surgery, almost all the conditions that presented we've now wiped out. Things like polio and typhoid and all the rest, they've all been wiped out. So logically, you might say, what would there be left for GPs to do? But the simple fact is GPs are busier today than they were back in the 1860s. And that then made me think, so 100 years from now, will when we've cured everything that's around at the moment, will there be nothing to do? And the answer, of course, is no, because it'll spread yet further. And I talk about the fact that I recently had cancer. I'm older than my father. My father died when my father died, he was only in his early 60s. He died of a heart attack. He didn't have time to develop cancer. He died before he got cancer. So the fact that I've been lucky enough to avoid having a heart attack gave me the time to develop cancer. Recovering from cancer may lead to the likelihood somewhere down track that I'll have other conditions. And so trying to be really clear about what we're trying to achieve. I don't think we're ever going to have a population that lives to the age of 150, happy and healthy and well, and then suddenly, die at 150. There's always going to be a need for caring doctors. And we need to really make sure that we focus on the critical things, the things that really matter to our patients.
What is it that a health system such as the NHS should try to achieve?
It needs to work a lot more with patients to be sure what matters to individual patients. We seem to behave as the one thing that matters is keeping you. This may sound crazy, but let me stay with it. We behave as if the one thing that matters is staying alive, rather than the quality of the life that you're having. So we have these extraordinary situations of people living in care homes who are very frail, maybe with dementia. And when they're coming towards the end, they're rushed into hospital where people feel there's a need to give them CPR if they go into cardiac arrest. This to me is completely crazy. And I'm not saying this because, I don't think elderly people should keep living. I'm an elderly person myself, of course but it's this automatic behavior that we focus on. We must do everything technical we can, rather than focusing on what matters to patients, their families, and so on. And I think we've lost our way on this.
I'm sure you've been on both ends, and as you said, with your personal experiences as a patient and as a physician. So I'm going to ask the question that you just brought up. What matters to patients then?
Well, I don't know, because it's important for doctors to talk to their patients, and again, this needs time. But there's so much really interesting research into if patients really understand the risks and benefits of particular treatments, they often choose in a very different way. I mean, so often, and particularly in the UK, and particularly in the recent past, a doctor will say, I think you need this. The patient will say, yeah, thank you, doctor. There's no real discussion of risks and benefits. And intriguingly, research among doctors themselves as patients find that they choose less treatment, fewer operations, fewer drugs than they prescribe to their patients. And I find that really fascinating. So doctors are much less likely to opt for particular types of chemotherapy, but they're very happy to offer them to their patients because they assume that's what their patients want. A friend of mine who's an American physician called Al Mully has written about this and calls this preference misdiagnosis. Doctors are hopeless, he says, at knowing what their patients' preferences really are. They jump to assumptions that a patient with a breast lump would like their breast removed, for instance, when that absolutely may not be the case. So having the time and the skill to explore these things really matters.
Do you think communication skills, compassion, what about compassion? How would that fit into this? Would that help?
Compassion is an absolute integral part of healthcare. And that's not just being nice. It's not just being a kind and friendly person. Compassion involves this genuine understanding of the position that the patient is in, or the full story of their what's going on in their life at the moment, taking that on board. And empathizing, sympathizing, being objective, of course, and providing the facts. It doesn't mean just rolling over and saying, to patients that whatever they want, they should have. It's a question of engaging with them in a way that really takes the patient's needs, experiences, fears, anxieties. I'm sure you've heard the phrase ideas, concerns, and expectations. Really understanding what the patients, what they think's going on, what they're worried might be going on, what they're expecting you to do about it. Doctors really need to take this stuff on board when working with their patients.
I wanted to bring up a few other stuff that you mentioned in the book, which is very interesting. Let's start with multimorbidities and then prescribing too many medications, handling that.
Yeah, I mean, multimorbidity, I talked a bit about this earlier, the fact that there are so many people who have multiple health conditions. And so much of our healthcare research and the use of guidelines is based around single conditions. Indeed, an awful lot of research in health issues, the recruitment for the research excludes people with other health conditions. So if you're looking at the management of, let's choose something. If you took it in the management of kidney problems, you exclude patients with any other problems from your trial because you really want to know what the impact of a treatment on the kidney is. The trouble is, most patients who present to most doctors do have other conditions. Guidelines, and I was chairman of NICE, as you said, for 6 years. NICE was probably the world's leading producer of guidelines, but most guidelines are produced for single conditions. And as a GP, I remember frequently seeing patients with, again, kidney disease, but also with arthritis. And you knew that if you used the treatments that were recommended in the guidelines for their arthritis, you'd make their kidneys worse. And if you used the best treatments for their kidneys, you'd probably make their arthritis worse. And this real skill required in bringing these together. So again, when I was with NICE, we worked on developing early guidelines to look at how you deal with multimorbidity, having multiple health problems. And the real importance, I think just taking that patient of mine I talked about earlier with 8 different healthcare conditions, if you applied the guidelines of perfect practice to each of those, you would end up giving worse care rather than better care because you're not taking into account the whole person. It's absolutely critical you take into account the whole person.
I think this also highlights the uniqueness of each patient. And it highlights even more the importance of having a GP who addresses this uniqueness, because when we go into specialty, then there's not much time to address this. I
mean, it's I think I talk about it in the book, but a situation I've come across is that of rheumatoid arthritis, where most research with working with patients with rheumatoid arthritis says the things that bother them most are the tiredness and depression that come with it. And that actually matters more to them than the swollen joints. And yet there's I've come across over and over again stories of people consulting rheumatologists, and the rheumatologist says, I'm sorry, that problem with depression or tiredness, I can't help you with that. You need to see somebody else. I'm here to help with your joints. Now, hopefully this attitude is changing, but you can't define a specialty by the bits that interest the doctor. You have to do it by the bits that matter to the patients.
What about the medicalization of this tendency to medicalize everything? I'll rephrase it. You have a very nice example in the book, which says the pharmaceutical industry trying to research basically into a medication to treat loneliness.
Yeah, I mean, it just seems too ridiculous to be true. And of course, loneliness is a really important societal issue. There's a lot of evidence that people who are lonely in the long term have far worse health outcomes, that social interaction is really important to our well-being as humans. And of course, loneliness can make you feel, develop a multiplicity of depressive type symptoms. So one of the pharmaceutical industries was certainly researching into medication that might help these symptoms. Now, this to me is just completely crazy. It's whilst I understand the importance of loneliness, surely the answer to that is to address society rather, to help people be less lonely by their interactions with other people, not by giving them a pill. And the approach of a pill for every ill, that whatever you present to a doctor with, you expect them to give you a tablet, is just a hopeless way forward for healthcare. We have to look at much broader humane ways of looking after people. I talk about a small town in England called Frome, where one of the general practices there has done a huge amount of work in encouraging and supporting social interaction across their patient group. And as a result, their health outcomes are dramatically better. Their hospital admissions are reduced. The use of emergency departments are reduced simply by focusing on these apparently non-medical things. We tend to wait till problems are medical and then give a medical treatment for it. And that is just not the way forward for healthcare.
It's amazing, though, how this also addresses the issue of underfunding. You can pour, we will have to pour ever increasing amounts of money into healthcare if we continue behaving the way we are. Every single country in the world, whatever the healthcare system, whatever the methodology for funding it, we see budgets going up, sometimes faster, sometimes slower. And I'm not talking about COVID here. I'm talking about the general trend over the last 30, 40 years, as every year slightly more being spent on health. And at one stage, there were calculations, there comes a point when 100% of a nation's GDP will be being spent on health. That is obviously unsustainable. You cannot do that. But it's the wrong way forward. It's just to assume that pouring more and more money in is always the solution. I use an analogy in my book, comparing shortage of money in the health service with anemia in patients. And doctors are aware that you can treat anemia with iron, because if the problem is a lack of iron, then you give iron. But if the problem is the patient is bleeding or the patient isn't absorbing the iron properly or whatever, you need to take a different approach. And I think this is also the way we need to look at funding in healthcare. You can just pour in more money, but that's like just giving iron to patients with anemia. If that's not what the problem is, you won't get anywhere. Mm-hmm. I want to let's shift focus now onto, you've had a lot of experience in leadership, and I wanted to hear about that. I wanted to hear your experiences and also any advice that you have to anyone who's in leadership now.
Yeah, I leadership's a fascinating subject, and one almost feels sort of slightly embarrassed talking about it. It wasn't something I ever sort of aimed or intended to get into. But I just feel in any organization I found myself leading, the critical thing is to set a tone for the organization, to set the values, because this can have an immense impact across the organization you're working for. If you're leading a healthcare organization and you make it absolutely clear that your priority is to earn more money, then that will have an impact on the behavior of everyone in your practice or in your organization. If your your main focus is on providing quality care for your patients or compassion or whatever, then that will have an impact. And it's surprised me how much impact leaders can have. I've worked with leaders who set very, very different tones, and I don't think they always recognize it. So it's being clear what you're really trying to achieve and restating this and living by your values and testing your values. This is the vital bit. I also feel if you are in any sort of leadership role, the key bit is to work with the best possible people that you can and let them get on with it. I think leaders who try and micromanage the rest of their teams are, it's not the most logical way forward. I think what I've been good at is setting tones. I'm certainly not much good at micromanaging, but and I don't think many leaders need to do that. They need to set a direction, set the values, set the behaviors, and that's the critical bit.
What kind of values were most important to you when you're in leadership positions?
It sounds in healthcare, I think it genuinely comes down to patient-centeredness. For keeping all the time, what really matters is the quality of care experienced by the people we're here to serve. And that's always got to be the number one. And then everything else follows from that. And so certainly, when I was with NICE, for instance, which was a huge sort of national and international organization, every time, I think every single lecture or presentation that I gave, I talked about the importance of compassion. I think when I was working with NICE, which is of course a large national, indeed international organization, in every single presentation that I gave to an audience anywhere in the world, or to the staff at NICE, or to the medical royal colleges or whatever, I talked about the importance of compassion and the importance of kindness and the importance of listening to patients. And over again, people would come up to me and say, afterwards, oh, I wasn't expecting that from the chairman of NICE. I was expecting something about evidence-based medicine. And I said, that's exactly what you got. The evidence is that things like kindness and compassion and so on are absolutely critical to quality care. But we've somehow decided, that the medical profession can be overly biomedically scientific at times and think that the only thing that matters is the dose of a drug, when actually the way in which the decision to use the drug is implemented can be every bit as important.
What do you answer to people that say, well, science is more important than kindness and compassion, because if you don't get the science right, then you get a dead patient?
But you're saying, well, not you, but anyone who phrases it like that is saying that kindness and compassion aren't scientific. Yeah, of course they are. The evidence base. Mm-hmm. I mean, I talked earlier about the evidence base for continuity of care, of relationships between doctor and patient, is extraordinarily powerful. Looking at blinded trials and so on, it's not as if that's a soft and cuddly bit of healthcare and the dose of a drug is the scientific bit. It's all science. I don't see these things as being an optional extra. And I'm not. And the last thing I'm saying is ignore the critical importance of the scientific bit. I'm just saying don't ignore the bit that does get ignored. The management of my cancer, it really, really mattered to me that the doctors used the right drugs and the right dose and so on. It also mattered to me that they were kind and compassionate and listened, and those things really made a difference to my well-being and ability to recover.
I think you frame it very well, because it's not that we undermine the importance of compassion, kindness, etc., but we have to value it as much as the science stuff, if we could label it like that.
Yeah, it is. But more than that, it is the science stuff.
It is, yeah, yeah. I heard one of the podcasts you did. I don't know when you did this podcast. I came across it, and you were talking about anyone who doesn't doubt themselves shouldn't be a leader. Could you expand on this? Because I really liked it.
I think, I mean, I think this was probably a discussion about imposter syndrome. And I think, most people, certainly in the early years of their leadership, will find themselves, standing in front of an audience or a group or whatever. And in their head, they're saying, what on earth are you doing here? Who do you think you are? And I actually think the moment you stop thinking that, you've got problems. You're getting a bit arrogant. You're getting a bit too big for you, big for your boots, as it were. So I think it really is understand that most people do have self-doubt, and if you don't have self-doubt, well, I get a bit worried.
How did you deal with self-doubt? I remember once. I was in Geneva, and I was about to address a meeting at the Assembly of the World Health Organization. And so there were all these ministers and senior civil servants from around the world in the audience. And I got up onto the stage, and in my head, I was saying to myself, David, what do you think you're doing? You're a country GP. What on earth are you doing here? And the other bit of my head was saying, yeah, what an opportunity. Just go for it. Tell them what you think. And that bit managed to take over. But, I recognized the ludicrousness on one level of what I was doing. But also, no, this is the chance to try and share my values. And, I couldn't have been more thrilled when the the then Secretary General of the World Health Organization gave me a thumbs up at the end of the presentation. It was, so I was in the right place. I was doing the right thing. But at the beginning of it, I was thinking, come on, mate, what are you doing? That's beautiful. And I'm sure a lot of medical students and in all kinds of professions, we find ourselves in positions like this. I want to go to some more personal questions now. We're reaching the end of our podcast. I know that you enjoy writing a lot, and I want to ask, why did you get into it, and why do you do it?
It dates back almost to school days. I had an English teacher when I was very young who gave me a passion for the English language. When I was a schoolboy, I helped write and produce humorous magazines for the pupils. When I became a medical student, I did some for the medical students' societies, and then when I first started in general practice, I remember writing a humorous article and sending it off to a journal that I really admired, and getting a letter back from the editor saying how much he'd enjoyed it and sending me some money. I mean, I couldn't believe this. It was just too good to be true. I mean, these days it would be a blog, for which there is, of course, no money, which is, but I just really enjoyed it. And then I just got into, I found that writing, I find quite relaxing. I don't find it terribly difficult. Indeed, I'm mystified why so many doctors in particular, when faced with writing, they start churning out totally different language to the language that they would use when talking to a friend. It all becomes, the average medical journal is full of the most appalling jargon that you can't imagine the authors talking over, For me, you don't have to be solemn to be serious. You have to get your message over, and if that involves writing in a way like conversation, it's not quite the same. It's not just dictating and taking that, but it's recognizing that the language needs to be accessible, and I've always enjoyed doing that.
I went on your website and I did read some of your blog posts, and I have to say it struck me, the fact that what you just explained, that the way that you talk is the way that you write, and I find it really enjoyable, and because reading is something that you have to enjoy.
Yeah, what I tend to do when I've written something, I then read it and say, would I have spoken like this? Now, that sentence I just said there was full of hesitations and messes, and I went back on myself and I repeated myself. So writing that down would have looked a mess. So I'm not saying write like you speak, but when you've written it, check, would you speak it? And if you're using language that's totally different, then go back and change it. So it's an interestingly different way around.
Mm-hmm.
I mean, as I've spoken this morning, and I'm doing it again now. You know, these sentences are a mess, so I would never write them like this. But every sentence that I write, I think you can read out loud, and it sounds normal.
I came across this interesting idea that the way that a thought or an idea comes about is you think about it, and then you express it in language, you discuss it with other people, you share it to see how other people react. And then the highest form of expression is writing. And then you sit down and you make this idea and you distill it to its core, to its core, and you write it down in a passage. And then that helps you, if you go back, that helps you, not only it makes you a better speaker as well, and also makes you a better thinker. I want your thoughts on this.
No, I think that's absolutely right. Absolutely right. And I've sometimes, started writing something and found as the writing is coming out that it's helping me understand what I think about the topic. That I don't. This may sound extraordinary, but at the beginning of if I'm writing a blog post or in the old days writing an article for a magazine or a journal, I quite often didn't know where it was going to end up. But the act of writing helped crystallize in my mind, discovered what I remember an extraordinary story. My earpiece has just fallen out. I hope my voice is still there. Still got me. Yes, I remember some years ago, a friend of mine who was at a council meeting at the Royal College of GPs, and there was this very, very eminent doctor sitting next to her, and he stood up to speak. And as he stood up to speak, he turned to her and he said, "I can't wait to hear what I've got to say about this." And I remember at the time thinking, that's an extraordinary thing to say, but I actually know what he meant, because he wasn't. He wasn't quite sure where it was going to go, but the act of speaking and presenting was crystallizing in his mind. I don't recommend we all do that, or you'll get all sorts of nonsense coming out. But but certainly writing gives you this opportunity, and then of course you go back and edit, and you sharpen everything up again.
I totally agree. And I find it fascinating, and something that I'm trying to do more, try and write a bit more about topics that I'm passionate about. I want to go to something else. What are you most thankful for?
Oh, I guess two things, my family and my health. The fact that I've got a family. I've got my wife, son, daughter, 3 grandchildren. They are, absolutely the world. And the fact that I got through my cancer, radiotherapy, chemotherapy, all the rest. I'm incredibly grateful for that. Almost every day after that is a bonus. So that's it's a very cliched answer, but it doesn't mean it's not true.
No, I think gratitude is it's a big virtue. Let's whiz through the rest. So, favorite book?
I think my favorite book, there was a book, a travel book by an author called Paul Theroux, called Great Railway Bazaar. And it started with the lines, if I can remember them, ever since I was born within the sound of the Boston and Maine, I've never heard a train go by without wishing I was upon it. And then it's the story of a long rail journey. And it just got me a passion for travel writing. I love travel, and reading travel writers, I think, takes me to places I haven't been and sees people I haven't seen. So I love travel writing.
Indeed. What about a favorite series or a movie?
Favorite movie was probably there's a movie, it's quite old now, but called Local Hero, which was set in Scotland and had the most wonderful music by a musician called Mark Knopfler, which I just absolutely adore, the music and the scenery and the story of the movie. Favorite series, again, it's a little old now, but it was a political series called The West Wing, set in a fictional White House in the US. And it just had this wonderful writing by Aaron Sorkin, some of the finest writing that I've ever seen. And it was immensely moving and showed you what politics could be like if we had a world full of sane politicians.
I'll be honest, I'm not familiar with any of these, and I am going to go and look them up.
For everybody, you know, their favorite things are of their generations. So my generation's favorite things are going to be different to your generation's favorite things. But I just certainly the quality of these are things that I've gone back. Right, we're okay again.
Yeah, no,
Okay.
I agree. But you know, some stuff that remains through the ages that's remembered.
Yeah,
I think it's worth going back and looking it up. Okay, and let's end on this question, and I'll let you go. What advice would you give to your younger self, to any aspiring healthcare professionals?
I think I said earlier that I never intended to do many of the roles that I've done. And I think the secret of a really interesting career is to turn accidents into opportunities, to when faced with an opportunity to do something, which may come about by accident, ask yourself, if I lived to the age of 99 and I look back on my life, would I have wished I'd tried this? And if the answer's yes, then give it a shot. And what's the worst that can happen? The worst can happen, you don't get appointed or you don't get elected or whatever. And the best that can happen is you may go off on a fantastic different tangent. So my life now, the career that I've had, makes absolute sense in retrospect. I can see that everything that I've done fits together. All the pixels come together to a picture that is my career now. But none of them were bits I deliberately went for. They just looked interesting at the time. So I think advice to any younger person is, when faced with opportunities, apply that test, what I call my deathbed test. You know, would you regret not giving this a shot? If so, go for it and have an amazing life.
Thank you. I think it's a wonderful note to end on. Thank you so much, Sir David, for being here and doing this with me.
Absolutely my pleasure, Andreas.